Vector is mosquito, and geographical distribution is Africa, Balkans, Europe, and Eurasia. Then there's a dengue fever, which is the most common among them, and the vector is mosquito. And the geographical distribution is Asia, Africa, Pacific, and Americas. Yellow fever, the vector is mosquito, and the geographical distribution is Africa and tropical Americas. So other the Kaisanur forest disease, that the vector for this is a tick, and it occurs in India. Most of these viruses affect the Africa and South Americas, and also few of them are endemic in Asia. So the features of these viruses, all are single-stranded RNA, all are enveloped, all are infectious during their viremic stage. They have a very low infectivity dose. 1 to 10 viruses can cause infection. They are geographically restricted to the areas where host lives. Humans are not the natural reservoir, but accidentally infected when they comes in contact with infected host. The human outbreaks are sporadic and irregular. When human is infected, can infect another human. There is no established treatment with few exceptions. The best treatment is the control of infection and supportive care. So epidemiology of hemorrhagic fever virus disease transmission. The hemorrhagic fever viruses are basically zoonosis. They have animal hosts, rodent and arthropod vectors are the main reservoirs. The natural infection of humans and mode of transmissions are the bite of infected arthropod, either ticks or mosquitoes. Aerosols from infected rodent excreta, as in Lassa fever virus, and the direct contact with infected animals or carcasses are from mites. So these are the various mode of transmission to the humans. So human to human and nosocomial transmission may be possible for most hemorrhagic fever viruses. Most person to person spread are due to direct contact with infected blood and body fluids like hospital acquired infections. Few of them also transmit through mucous membrane contact, aerosolized as airborne in Ebola, Lassa, and Guinean virus. Also can transmit through semen, vomitus, and sewage. Incubation period for most of these hemorrhagic fever viruses are ranging from 2 to 21 days. So the pathogenesis, the target organ is a vascular bed leading to the hemorrhage. The replication of the virus occurs intracellularly. The cytokine release leads to the shock and hypotension. They affect the platelet functions and counts, leading to the thrombocytopenia. It also affects the bone marrow and clotting factors, leading to bleeding diastasis. So the case fatality or mortality rate. The flu viruses, in which the Ebola virus have a highest mortality rate up to 70 to 90%. In flaviviruses like dengue fever, in which there is a mortality 0.5% to 2.5%. And 20 to 50% in severe cases of yellow fever. For arenaviruses, the mortality rate is around 15 to 30%. So the cause of death in most patients is hemorrhagic diastasis, bleeding from different body orifices and sites, and also leading to shock and multi-organ failure. So the differential diagnosis of viral hemorrhagic fevers. So there are different conditions that can mimic these viral hemorrhagic fevers. We have to think of other medical conditions because they simulate with these viral hemorrhagic fevers. The influenza, because these persons have high-grade fever, sore throat, and also body aches, myalgias. So we have to keep influenza in our differential diagnosis in initial stages. Viral hepatitis, as most of them affects liver and also raised aminotransferase levels and development of the yellow discoloration of the eyes, staphylococcal or gram-negative sepsis. Meningococcemia, as these have different skin rash lesions, ecchymosis, and also salmonellosis and shigellosis, leptospirosis, malaria, and diphtheria disease. The non-infectious conditions which we keep in our official list include DIC, because these are bleeding diastasis, bleeding from different orifices, decreased platelet count, and ITP, immune thrombocytopenic purpura, TTP and HUS, thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome, as there is a decreased platelet count, oliguria, renal involvement, and acute leukemia, as there is bone marrow involvement, vasculitis, collagen vascular diseases. So this is a list which we will keep in our differential diagnosis of viral hemorrhagic fever. So number one is the flow viruses. These are the Ebola viral disease and Marburg virus. They can be used as a bioweapon or bioterrorism agent, potential to cause widespread illness or death, ease of dissemination or person-to-person transmission, and first appeared in Zaire and Sudan simultaneously in 1976. Then there was another big outbreak in 2014 in Guinea, then to Liberia, Sierra Leone, and lately Nigeria. So these are the African countries in which this Ebola virus spreads. Then there is a case fatality rate approaches to 70 to 90%. The virus was transmitted to humans from wild animals. Fruit bats are considered as the natural host for the virus. So the Ebola virus disease transmission by direct human-to-human contact with the blood or body secretions like saliva, breast milk, tears, stool, skin, or cell. Infected persons are even dead bodies. So our livestock is at risk. Transmission through semen may occur up to 7 weeks after clinical recovery. Indirect contact or transmission via environmental contaminated with such infected secretions by handling ill or dead infected chimpanzees or other infected animals. So these are the various modes of transmission of Ebola virus, and also healthcare workers have frequently been infected while attending infected patients because they have direct contact with body fluids, needle stick injuries, and aerosols or droplet infections. So this is a picture showing the paramedical staff are engaged in care of these viral hemorrhagic fever patients. They are using full protective gears, which are we see in this picture. So they cause severe hemorrhagic fever that's similar to fulminant septic shock. Mortality rate in case of Ebola virus 70 to 90%, and in case of Marburg virus is 25 to 30%. Incubation period for Ebola virus is 2 to 21 days, and mean or 8 to 10 days. And for Marburg virus is 3 to 10 days. So this is a picture of flow virus, that's Ebola virus. Then this is a picture showing there was a conjunctival injection, and also there was a rash over the lower back that's mimicking with meningococciemia, and also there was an ecchymotic rash of the arm. So this is also severe patient in ICU. There is bleeding from the nose, profuse bleeding. So then coming to the flaviviruses. Flaviviruses contain yellow fever virus, dengue fever, and Caisseneur forest disease. So the mode of transmission for yellow fever virus is an Aedes mosquito, and for dengue fever are the Aedes aegypti. And Caisseneur 4 disease are the tick bite. There is no reported cases of person-to-person transmission in flavivirus. So yellow fever virus spreads through, there's 3 cycles. There's a jungle cycle, urban cycle, and intermediate. In jungle cycle, the mosquitoes infect the non-human primate, then again mosquito bite them and infect it, and again then infect the non-human primate. And if mosquito infect the humans, and then again Mosquito bite to the humans and transmit to another human. This is an urban cycle. And then is an intermediate in which the human or non-human primate can be infected by mosquitoes, and so they can spread to the various villages and spread disease over there. This is a picture showing the flavivirus in which you can see the outer capsule, and there is an E dimer, then there is an M protein and capsid protein, and then there is a genomic RNA. So the yellow fever, the incubation period is very short, 3 to 6 days. Initial symptoms, as we have already discussed, the fever, chills, severe headache, back pain, muscle aches, nausea, fatigue. Most of the symptomatic patients develop only this stage. However, among them, 15% of the symptomatic patients will lead to the toxic shock phase, in which the fever returns with the initial symptoms, plus patient also develops coagulopathy and hemorrhage, and also hematemesis, and then there's a jaundice, hypotension, shock, metabolic acidosis due to renal involvement, arrhythmias, confusion, seizures, and coma. So there's a picture showing the signs and symptoms of the yellow fever virus. There's a red eyes, headache, bleeding from the eyes, nose, mouth, fever, vomiting, back pain, muscle aches, and then there was a hepatomegaly. So the majority of the person infected with yellow fever virus have no illness or only mild illness. There's a relative bradycardia with fever. Mortality rate is 5 to 10%. And in epidemics and hospitalized patient, there is a mortality rate is 20 to 50%. 90% of the yellow fever cases occurs in Africa and 10% in South America. Now the vaccine is available for it, and it's indicated to the travelers which are visiting the endemic areas in Africa continent and South America. It's a live attenuated vaccine. A single dose is enough for lifelong immunity. It can be offered to the persons who are above the age of 9 months and those who are living in endemic areas. Immunity develops in 1 week in 95% of people, and protection, as we have told, is up to more than 30 to 35 years. There is no specific treatment available for this yellow fever, and only there is a supportive care. So this is a picture showing the map of African continent, in which you can see the countries with yellow color are endemic to yellow fever, and 90% of the cases occurs in Africa, while there is a map of South America, in which the countries with yellow color are endemic zone of yellow fever, like Brazil, Bolivia, Peru, Colombia, Venezuela. So then there is a Benia viruses. There's a rift. It includes Rift Valley fever viruses, hantavirus, and Crimean Congo hemorrhagic fever. The viral hosts include arthropod vectors and rodents. For Rift Valley fever virus, the vectors are the mosquitoes, and for Crimean Congo fever are the ticks, and for hantavirus are the rodents. All can be acquired by exposure to infected animals or their carcasses, contact with blood and bodily secretions of infected persons, and by aerosol transmission. So the Rift Valley fever, mosquito-borne disease, it primarily affects the sheep and goats and cattle. Most human infections are inapparent, present self-limited febrile illness. The first reported case of the Rift Valley fever occurs in the Kenya's Rift Valley in early 1910. So that's termed as Rift Valley fever. There is an also rare severe form occurs in which there is an ocular involvement in the cases of retinopathy and meningoencephalitis or hemorrhagic form. 1% develops typical viral hemorrhagic fever, short incubation period, mortality is less than 1%. So human acquired infection by bite of infected mosquitoes, and also contact with infected animal tissues, and aerosolized transmission of virus from infected animal carcasses and also to livestock. There is no reported cases of human to human transmission. Standard precautions are enough. Vaccination of animals, but not during epidemics. Inactivated human vaccine is not licensed for use. So there's a picture showing of world map. The countries with the blue color are endemic zone for Rift Valley fever virus, mostly of the African countries and Saudi Arabia. So this is again picture showing a large map which color in blue are the zone for development of these Rift Valley fever virus distribution. So then there is an arena virus which include the Lassa fever virus and the New World arena viruses. So arena viruses are the rodent-borne hemorrhagic fever viruses, mainly rates in rodents. Severe hemorrhagic fever virus in Africa and South America. Incubation period is 3 to 19 days. There are two types, Old World and New World. In Old World in Africa and Europe is the Lassa fever, which causes a lymphocytic choriomeningitis. New World affects the Americas, and these viruses include South American hemorrhagic fever viruses, Junine viruses, which is also termed as Argentine hemorrhagic fever virus, Michupo virus, and whitewater Oreo viruses and Sepia viruses. So mode of transmission of these viruses are the inhaled aerosols of rodents, urine and feces, and also ingestion of food or water which is contaminated with these rodent excreta, or direct contact of rodent excreta with abraded skin or mucous membranes, or contact with the contaminated fomites, or contact with the rodent blood. Sexual transmission may occur in the Lassa virus. So person-to-person transmission does occur with the direct contact with blood, urine, pharyngeal secretions, and other body fluids of patients, especially in healthcare workers. Airborne transmission is possible from patient to healthcare workers. So this is a picture showing the rodents, the rat-like structures. Then coming to the dengue fever, which is the most common febrile illness after malaria and respiratory tract infection. It is described as breakbone fever by Benjamin Rush in 1789. It is endemic in more than 120 countries of the world, and endemic throughout the Americas, Asia, and Africa. Vectors are the mosquitoes, Aedes aegypti and Aedes albopictus. Virus replicates in mosquitoes, very rare by blood transfusion, organ transplant, and vertical transmission. The incubation period is 3 to 14 days. Because the dengue is recorded as breakbone fever, because it causes a severe body ache, myalgias, muscle ache, and patient feels that there was a breakbone, like a fracture of the bones. As you know, the bone pain is very severe in intensity, so that is termed as a breakbone fever. So incubation period is 3 to 14 days, and mean days are up to 9 or 10 days. It's the most prevalent mosquito-borne viral disease in the world. 1/3 of the world population are exposed to this virus, and 400 million cases occurs annually. It affects more than 120 countries and is an endemic over there. In USA, the data are the dengue affects 10.4% of the post-travel systemic febrile illness in travelers which are returning from the endemic areas. Now the vaccine is available, which is a recombinant live attenuated tetravalent dengue vaccine, and which can be given in patients to endemic areas. There is no specific treatment, only supportive care. So this is a picture of the world map, which is showing the countries which are endemic to dengue fever. The countries which are yellow in color, you can see most of the continents of the world are affected with this virus. There are 4 serotypes of the dengue virus, 1, 2, 3, and 4. All can cause severe and fatal infection. Infection by one serotype gives no cross immunity Yes, Pakistan is also endemic. We have several endemic, these are the epidemics also of dengue fever. From 2006 and onward, it occurs annually. Majority of our population, especially in urban areas, as you have known that in Lahore, especially Punjab and Lahore, there are the major outbreaks occurred in the past, and also in Karachi, because it occurs after the rainy season, when which is suitable for the breeding of the mosquitoes. So infection by one serotypes gives no cross immunity to other types, but lifelong immunity to the same type. If a person which has infected with one serotype, if it develops infection next time with another serotype, there is a more predisposition that he will further develop dengue hemorrhagic fever or dengue shock syndrome. It's a complicated pathogenesis and partially attributed to antibody-dependent enhancement. Humans are the main reservoir. So these are the symptoms of dengue fever. There are 4 stages: febrile phase, in which there is a sudden onset fever, headache, mouth and nose bleeding, muscle and joint pain, vomiting, rash, and diarrhea. Then there's a critical phase, in which there's a capillary leakage occurs, which leads to the hypotension, pleural effusion, ascites, and gastrointestinal bleeding. And then there's a recovery phase, in which there's an altered level of consciousness can occur, seizures, itching, and slow heart rate. So there are 4 clinical manifestations of the disease: undifferentiated fever, then there's a classic dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. 80 to 95% of the patients with the dengue develop mild fever, and 5% can lead to the development of severe dengue, leading to the dengue hemorrhagic fever and dengue shock syndrome. So the classic dengue fever, in which there's an acute febrile illness, high-grade fever with chills. There's a severe headache, mainly retroocular, behind the eyes. Myalgias and arthralgias, which are often severe. Nausea and vomiting occurs in more than 50% of the cases, and diarrhea occurs in up to 30% of the cases. Rash occurs in 50% of the patients, which is of variable appearances. There's a maculopapular rash, petechial rash, or erythematosis. Petechial rashes are common in the picture. You can see there's a conjunctival injection of a patient on the left side. On the right side, you can see there is a petechial rash over the back of this patient. So then there's a dengue hemorrhagic fever, is the most serious form of dengue infection. WHO estimates that there was a more than 5 lakh cases of dengue hemorrhagic fever occurs every year. Mortality is 10% and can increase up to 50% if the proper treatment is not given. There are 4 diagnostic criteria, in which the fever, there's a high-grade fever, there's an hemorrhagic manifestations, and low platelet count, less than 1 lakh, and evidence of leaky capillaries in the form of pleural effusion and ascites, severe abdominal pain, persistent vomiting, then dengue shock syndrome. When there was a dengue hemorrhagic fever plus evidence of circulatory failure or shock, in which we found in patients of rapid, weak pulse, narrow pulse pressure, hypotension, there's a cold, clammy skin, and sometimes altered mental status. Rashes are due to the increased capillary permeability and also due to the decrease in the platelet count. As you know, the small injuries are occurs in the capillaries, which are plugged with the platelets. As platelets functions and count is disturbed, so there's chances of increased bleeding and rashes. So diagnosis, management, and control of viral hemorrhagic fever. So the patients must have high-grade fever, no predisposing factors for hemorrhagic manifestations, and no established alternative diagnosis. Along with that, there are also signs and symptoms of severe headache, muscle pain, erythematous maculopapular rash on the trunk with fine desquamation, And after the rash, there is a vomiting, diarrhea, abdominal pain, thrombocytopenia, bleeding which is not related to injury, the pharyngitis. And also you have to dig out the history, the important history, that patient might have history of travel from going through or from coming from endemic areas within 3 weeks. Even if non-specific signs and symptoms are not present, the comprehensive travel history is critical. And also there is a history of tick or mosquito bites, also contact with mice or their excreta, or history of contact with patients with above risk factors, and these symptoms. Also contact with sick animals or carcasses in endemic areas. So non-specific lab abnormalities which include in blood CP, you can find leukopenia, sometimes anemia and hemoconcentration as in cases of dengue fever, thrombocytopenia, elevated liver enzymes, especially ALT and AST, because of the involvement of the liver and azotemia. Then there's a coagulation abnormalities, prolonged bleeding time, PT, APTT, increased FDP, fibrin degradation products, decreased fibrinogen level, and DIC. Specific lab diagnostic tests in these hemorrhagic fever viruses. There are different tests from which we can confirm the presence of these viral hemorrhagic fever. These are the antigen detection by PCR. These are the early rapid diagnostic tests, and antigen detection by ELISA test. As we do in dengue fever, there's an NS1 antigen in initially 5 days. IgM detection by ELISA, which is a slight late manifestations, and viral isolation in culture, which takes few days. The treatment of hemorrhagic fever viruses infection. There are the supportive treatment, which is the main history of treatment. There's isolation of the patients when there's an airborne spread of infection is suspected. Fluid and electrolyte balance, supplemental oxygen and mechanical ventilation is needed in few cases. Specific antiviral treatment. There's no FDA approved antiviral agent, especially for Ebola. In Ebola, we can use the favipiravir and remdesivir. Ribavirin used in arena viruses and Benia viruses. Ribavirin is not active against flow viruses and flaviviruses. Aspirin and NSAIDs are contraindicated in these patients. Anticoagulant therapies are also contraindicated. There is no benefit of steroids. The supportive treatment is the mainstay of treatment. The circulatory and BP support is mandatory. Early vasopressors, IV fluids should be given. Sometimes patient may need blood products, especially platelets and clotting factors and FFPs. As in dengue, when the platelet count is less than 10,000 or then there is a major bleed, then we have to transfuse platelets. Pain control, and there are chances of secondary infections. So sometimes aggressive treatment with antibiotics is needed. So infection control guidelines stick to the standard precautions. Report suspected cases immediately to the infection control authorities or Ministry of Health. Isolation of all suspected cases, and in those when there is an airborne chance of infection, keep them in a negative pressure room or a single room. Strict hand washing of the attending persons, double gloving, use of impermeable gowns, N95 mask or powered air purifying respirator, the leg and shoe coverings. The negative pressure rooms are specialized rooms in which the different machines are used which keep them negative pressure so that the air is sucked outside, which contains the infective virus so that the viral load is decreased. Face shields and goggles. All contacts of patient diagnosed with hemorrhagic fever virus include hospital personnel and lab workers should be placed under medical surveillance if there are signs of viral hemorrhagic fever infections for up to 3 weeks. Thank you all for patience listening. The red eyes in which yellow eyes in which there is a lemon yellow tinge, and while the red eyes you can see the bleeding behind the conjunctiva, under the conjunctiva. It is easily differentiated. Red eyes have a blood color while the jaundice is a yellow tinge. Thank you all for patience listening. If you have query, you can come to me, you can ask. I am in medical ICU. As nowadays, you know, the viruses are also common in Pakistan. Like we have these COVID viruses in which we are using all protective gears. So these outbreaks occurs in the different countries of the world, but some have special geographical distributions as these hemorrhagic viruses have. Thank you all once again.